Thank you for joining today. Um, it's happy to see there are quite a lot of numbers there. So I can see some people joined last time as well. That's good. So today we thought of discussing some questions with you, past papers, true and false questions, and single best answer questions, SBS, which is new to you. So let me share my presentation. But first of all, I want to tell you like this should be actually I accept if you like talk with me because it's needed. Otherwise, you will get bored. So then you won't get a maximum out of this lecture. So I hope that you will talk with me, at least message, leave a chat. Okay. So let me share my presentation. Sit. I think I have to open it first. No? Wait, give me a second. So, screen with you guys. Can you see my screen? Can you see it? Okay. Hello? Hello, can you
Yes,
see?
yes, we can see it. Yes, yes.
Okay. Okay, thank you. Thank you for talking. Okay. So let's start. Okay, this first I will start from true false questions. So my first question is taken from 2023 RPM paper. It's regarding hallucinations. So I will give you 1 minute. So read the question and jot down your answers and let's discuss. Okay. Have you guys finished answering the question? If so, can somebody tell me the answers? Or you can put your answers, write your answers in the chat box. You can get wrong, that's okay. No one is going to like criticize you guys. Okay, this is a learning activity, so we can together work out how it is. So it seems there are 22 people, maybe 20. Yes, yes. Thank you for answering. Good. Is that true, false, true, 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 false? Yeah, yeah. Okay. Mm. Mm. Okay. So hallucinations. Today actually we are talking about the psychopathology because it's a foundation of psychiatry. If you know the psychopathology really well, like then the other things that you can learn based on these psychopathologies. So the first question is A, occur in external objective space. So most of you have told me that it's true. Okay. Good. So yeah, hallucinations. Yeah, it occurs in external objective space. It means like the patient feels like actually there's something image in the outer space. Okay, it's external objective space. So, uh, so then what are the other modalities, like other psychopathologies that you can see in internal subjective space? So the other term is, the opposite term is internal subjective space. Can you tell me what are the other perceptual abnormalities that you know which are occurring in internal subjective space? Just one. Have you heard any? Hmm. So have you heard about the pseudo hallucinations? So pseudo hallucinations, they occur in internal subjective space. Okay, not the external objective space. So then this is occur in external objective space. That's true. Okay, it's like a normal perception to the patient, where you and I see something in outer space, like they see like this visual perception in the outer space. So B, experience as a true perception. Your answers, yeah, most of you have given it correctly. That's also true. No? So you experience, like the patients experience them as true perception. They think they are real. So the vividity, the quality of the perception will be close to the normal true perception. Okay. So that's why they think they are very real. That's also true. So A true, B true. The C, temporal lobe epilepsy may give rise to smell and gustatory hallucinations. Most of you have answered correctly. That's also true. It's a temporal lobe epilepsy, specific type of epilepsy. So it will give rise to smell, like olfactory hallucinations and gustatory hallucinations, the hallucination in taste modality. Okay. So one new message, let me see. Can you explain what is pseudo hallucination? Yes. So pseudo hallucination is a type of like perceptual abnormality, like hallucination, pseudo hallucination, illusions, imagery. Those are perceptual. These are like perceptions, no? So this is pseudo hallucination, also a perception, so that the patient feels like perceive there's kind of a stimulus which occurs inside. So in internal subjective space. So they don't see like hallucination. They say like clearly that they have seen somebody else out there. But these people, they don't have that reality. Like it's not like a true perception. So they have some sort of this um, unreal. They feel it like they know, they have some sort of idea that this is not that real. This is unreal. So it occurs inside them. Okay. So this can occur in states like when you're having some sort of kind of a very emotional states. Okay. In normal people also can get pseudo hallucinations, like usually normal people. So then yeah. So that's a pseudo hallucination. But the thing is, like, we are not going to go and label that is a pseudo hallucination, because if it is a hallucination, so they clearly say it's a hallucination. If it is not a true hallucination, so usually we are not labeling, because the patients are having very difficulty in explaining what a pseudo hallucination is. Okay, so in clinical practice, it's very difficult to elicit also. So deja vu is, no, deja vu is something else. Like deja vu is you feel like deja vu and jama is you. Okay, there are two terms. So you feel like something has happened before. I have seen these people before, like this thing had happened to me before. Like usually we also experience, it's a kind of a normal people also can have these kind of feelings. So when you see somebody, when you go to some place, or when you encounter something, you feel like this had been happened before as well. Okay, so this feeling we label it as deja vu, that can occur in other conditions as well, psychiatric conditions as well. But this is it. Jamaisu, like the other way around, like deja vu is like something uh, uh, the past. It's past. The Jamaisu, as I remember, actually, I'm not very clear. I cannot clearly remember. Let me check. So I have never seen, like, it's like this. So then that's unfamiliar thing. We feel like this something has happened before, very familiar. But Jamaisu is other way around, like unfamiliar. Like something is very familiar to us, we feel like it's very unfamiliar. This has not happened before. Like kind of this, I have not seen this before. Like kind of opposite. Okay, so it's different from pseudo hallucination. Okay, I hope that you have understood it very clearly. Uh, if there's any clarification needed, you can tell me. Okay, so A true, B true, C true, occur in heightened emotional states. Hallucinations, usually not. So you can have pseudo hallucinations and illusions. Okay, we will discuss it later, like illusions, there's, I think, MCQ. So usually not. Hallucinations you can have, usually hallucinations will be there in psychiatric conditions, schizophrenia, bipolar, depression, okay? So organic conditions like brain pathologies, like kind of tumors, okay? Epilepsy, and then, yeah, so these sort of situations you can have hallucinations. And there's other, like, however, like, though there will be psychiatric disorder associated with hallucinations, normal people, healthy normal people also can have hallucinations. As an example, when you are going to sleep, you can have hypnagogic hallucinations. When you are waking up, normal people can have hypnopompic hallucinations. Okay, there are two terms, hypnagogic when you are going to sleep, and hypnopompic when you are waking up. In normal people also, they can have, like, when you are going to sleep, like somebody, when you are in between the sleep and wakefulness, like somebody called me, like I heard some voice calling me, kind of sort of hallucinations can occur. They're normal. But okay, most of the time, hallucinations are associated with psychiatric conditions. Can be terminated at will. It's false, no? Hallucinations, you can't terminate at will. Okay, pseudo hallucinations also, you can't terminate at will. Okay. So I hope that you have got the answers. Okay. So I'm checking your chat box to see whether you have sent me any questions. Okay, are you clear with the first one. Shall we move on to the next question? Okay. Answers again. True, 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 false, and false. Okay. So the next question. Okay. So yeah, I told you that there will be a question on illusions. Okay, this I have taken from your 2023 past paper, ERPM. So regarding illusions, occurs in heightened emotions that I told you, no? Pseudo hallucinations, illusions, they can occur. Illusion means actually what is illusion? So you see uh, elect something like some tree, and you think like in dark you see a tree, and you think like, oh, you see there's some shadow is going on, so you think there's a man. Okay, you misinterpret or misperceive that tree as a man. Suppose small tree, so you think that's a man. So that's the simple way that you can explain illusion. Okay, so it's like that. So you misinterpret the perception that you are getting, you misinterpret it. You think that is something else. Simply, it's like that. Okay, that I hope that you also have encountered situations like that. Okay, so yeah, A occurs in heightened emotional states when you're very anxious. Okay, you can see, you can have these illusions. Then common at daytime than night. Sorry, I couldn't let you answer the question. I was talking. Uh, you can get 1 minute and answer the question. Okay. I hope you have answered. I have got some answers as well. Okay, thank you. Uh, yes. So yeah, I have told, I think, some answers I have told you already. So occurs in heightened emotional state. Yes, true. When you're very anxious, you can see. Common at daytime than night. So usually illusions occur, uh, as I told you, when at dark, like we tend to misinterpret. So, okay, so then this is false because it's more common at night, okay, than the daytime. Okay, when uh, the other the out when it's dark outside. So by the evening, by night, okay, so you can have these illusions that people can have. So occurs in normal people, true. I have told you, like we also have experience, so it can occur in normal people as well. So occurring the D occurs in cannabis withdrawal. So actually what I found was, when I was going through these questions, like I just did some literature survey. So they have mentioned in cannabis intoxication. When you're under the influence of cannabis, you can have illusions. But in cannabis withdrawal state, they have not mentioned like about illusions. But when you're like when people are having cannabis withdrawal, they can have this anxiety. So severe anxiety. So then we can work out. So because of that anxiety, they can have illusions. So that's what I thought of, but I'm not very sure because they say in cannabis, they have mentioned illusions in cannabis intoxication. or they are already like on cannabis, or they have under the influence of cannabis, but I'm not very sure about this answer. Uh, I don't know whether uh, I don't know where from where they have taken the question, but I can work out that because they can have anxiety, so they can have illusions. But because it's a true false question, if I were you, I will not answer this question. I will leave it because it's not mentioned specifically in textbooks, okay, or anywhere like in other literature. Very clearly, they have not mentioned. So there's the art when you are answering true false questions. So that's art. So if you are not very sure, so better to avoid that marking that question. So I can't give you straightforward answer for this STEM because it's not there in books, standard textbooks. So, okay, you can choose to leave it if you get this question. If you have read it or if you know exactly somewhere, if you found somewhere, you can tell me, like, so I can also learn from you. So then E, seen in delirium tremors. So they say like illusions you can have when your conscious level is altered or reduced. So in delirium, your conscious level will reduce. Delirium tremens is also the sort of a delirium when people get when they are withdrawing, like in alcohol withdrawal. Okay, so then their conscious level is reduced. So then they can have illusions as well. What they clearly mention is they can have you heard about Lilliputian hallucinations? Okay, that is also coming in next question, one of the next questions. So I will tell you when I go there. So they can have hallucinations as well. Lilliputian hallucinations. So because their conscious level reduce, so they can have illusions as well. Okay. So I hope that I have answered this question like A, it's true, B, false, C, true, D, I elect not to answer, but my explanation was in cannabis intoxication and your people under the influence of cannabis, they can have illusions, but withdrawal, they can have anxiety. So there's a chance that they can have illusions, but I elect, if I were you, that I will not answer this question. I will leave it. So E, seen in delirium tremens, true. Okay. So apart from that, in this question, I wanted to tell you regarding illusions. So have you heard the word about pareidolia? Okay, pareidolia. So pareidolia is also a type of illusion. If it comes in one of your questions, you can get questions like pareidolia is a type of illusion. Like I think you all must have experienced this pareidolia. You have when you see the sky, you see clouds. So in clouds, when we were very young, when we were small children, we used to see some shapes of animals. Okay, so we used to like tell, oh, I see a horse, I see cat, I see dog in that cloud. Okay, so that's called pareidolia. It's a type of illusion. Okay, your perception is altered. Okay? It's not a hallucination, it's not pseudo hallucination, it's an illusion, type of an illusion. Okay, pareidolia. Remember it. It can be asked. So that's also an example that illusions can occur in normal people. Okay, hope that you have got the answers. If you have any questions, you can ask in the chat box. So with that, we'll move to the third question. So it's again regarding hallucinations. Okay. So take 1 minute and answer the question. I hope some of the stems that we have discussed already. So you can answer. Somebody have asked about apophrenia, no? So it's interesting that I'm also learning from you guys. Psychiatry is it's a vast area. So this is interesting. Yes. Yeah. Apophrenia is also same like pareidolia. So it says apophrenia, like pareidolia is a type of apophrenia. Apophenia. Yes. So it's a tendency to like we see some connections or patterns in some unrelated events. So that's the definition it seems. So superstition, pareidolia. So they give as example. So superstition means like they believe like because of these things can happen. Like we tend to in Sinhala also we think like මෙන්න මෙහෙම නිසා like it will like the good thing will happen because of these things. So because of these things, the bad luck will be there. So good luck and bad luck, we tend to uh, decide on based on irrelevant things. So it's like that. So pareidolia is a sort of apophenia, yes. So it says it's a cognitive kind of a bias. Yeah, that's a good question actually. I'm also learning from you guys. As I told you. Okay. Oh, okay. Then just wait. Okay, let's move to the question. So it's regarding true hallucinations. You have answered, let me see, true, false, false, true, false. False, 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 true, false, false, true, false, true, false. Okay, we'll see who have got it correct. So true hallucinations. Can you induce hallucinations by suggestions? No, ne? So you can't induce hallucinations by suggestions. Okay. So then it's false. Occur in a subjective space. I told you it's occurs in outer objective space. Pseudo hallucinations in a subjective space. So that's false. So false, false. Okay. After cataract surgery. Yeah, that's true. It's called actually like there's a syndrome called Charles Bonnet syndrome. So where you can get visual hallucinations in people, usually after cataract surgeries. So it says like when you replace the lens, if there are existing visual impairment, so they can have this visual hallucinations. Okay, so yeah, after cataract surgery, it's true. Okay, in people with visual impairment, they can have visual hallucinations. Okay, as people with hearing impairment, okay, they can have auditory hallucinations. Okay. So that's true. After cataract surgery, they can have visual, not all, but some will experience visual hallucinations. Okay. So there's a syndrome called Charles Bonnet syndrome. I don't know whether you have to know the names, but there is one. Okay. So D, occurring depressive disorder. I hope that you know that's true. Can occur. Actually, I don't know whether like your seniors probably have taken down these questions and made up these question papers, like because it's very stressful given limited time. They have to by heart these questions and bring for the future for you guys purpose of the future kind of future ERPM students. So then I don't know whether they have jot down the full question. So true hallucinations can occur in depressive disorder. So it's not always. So if the depression is severe enough, like usually in severe depression, you can have hallucinations, usually auditory VC, auditory hallucinations, which gives derogatory kind of comments on people, like usually second person, like telling you are a bad person, okay, you are not worthy kind of. So in ICD-11, in moderate depression also, they can have these psychotic symptoms, including hallucinations. So they can occur in depressive disorder as well. If the question like it asks occur in depressive disorder, you can't tell it false, no. So that's the art of answering questions like occur in depressive disorder. You can't tell hallucination does not occur in depressive disorder. So they can occur in depressive disorder as well. Okay. So you can't mark it false because they occur. So then it should be true. So E, occur in normal people. As I told you, minority of people, normal healthy people can have hallucinations, including hypnagogic, hypnopumping. Going to sleep and waking up sleep, they can have this normal, like, they can have hallucinations. So can occur in normal people as well. Not always. So when you are answering, see, occur in normal people. If you put it false, so you mean hallucination cannot occur in normal people. Okay, so that's wrong. I hope that you have got my point. Okay, so they can occur in normal people as well. So A false, B false, C true, D true, E true. Hope that you have got the answers. Okay, shall we move on to the next question? Oh, so sorry. I'm not talking to you. Like my microphone was off. Hope now you can hear me. Did you hear about the things that I was talking about, hallucinations? Okay. So let's move to the obsessions. Okay. Take 1 minute and answer the question. Just few seconds, I think. 30 seconds will be enough for you guys if you were there for my last lecture. So there are few who are interacting. I hope the others also will interact and type their answers, because no one is going to criticize you guys. Okay, because we all are learning, including me. Okay, we are still learning. So that's okay. You make mistakes here, but at the exam you will do better. So I see Marin, if I pronounce your name correctly, and Kavindu Vijay Sundara. Yes. Jai Rupan, Tilanka Gunaratna. Yeah, very good. Yeah. Hiruni. When I was a student, I also, like you guys, like I was like that. I was not talking. I was not answering questions. Okay. But now I feel like I could have done better if I have asked more questions. Okay. So in this question also, I think the E, obsessions, can be linked with checking rituals. Probably there had been some more words to that stem E. Yeah. Suppose that there had been like obsessions can be linked with checking rituals. Okay. Okay. So, yeah, obsessions. Are they pleasant? Do they enjoy the people with obsessive compulsive disorder? Do they enjoy obsessions? Do they feel they are very pleasant to them? Hmm? No, ne? In my lecture, I told you they are very unpleasant. They are unpleasant to them. Okay? So, they feel like the thoughts are obsessions, the obsessive thoughts are senseless, no? No point, like there's no purpose, like senseless things. Okay? So, repetitive. They frequently pop up. So, repeatedly they pop up in the mind, like they come. Then, they are subjectively distressing. That's also true. So, it's very distressful for the patient. So, today also I saw one patient. So he's getting obsessive thoughts, doubts, impulses. So very distressing for the patient. Okay. So they can link with checking rituals. Okay. So that's true. So A false, B true, C true, D true, E true. Okay. So only A is false. They are recurrent, intrusive, repetitive, senseless, unpleasant thoughts, impulses, doubts. Okay. Subjectively very much distressing. So the definition should be like that. Definition of the obsession. So they can be linked with checking rituals, washing rituals, okay, counting rituals, the compulsions, the motax, obsessional motax. Okay. Hope you have got the question, the answers. Okay. Yeah. So again, the fifth question is also regarding obsessions. I told you that just before. Obsessions present as intrusive. Yeah, they can present as intrusive thoughts. It can just be a thought or rumination. So they might be debating inside their mind about a topic or many topics. Okay. There could be obsessions like that, obsessive ruminations. Then there could be obsessive impulses. So they feel like hitting somebody, they feel like killing somebody. Okay. Likewise, stealing something, the impulses. So E, visual imagery. They see imageries like obsessional images, internal, subjective space. So they get these images within their mind. Okay. The depersonalization, usually not. It occurs in severe depression, like kind of a depressive states. Okay. Depersonalization means like you are not feeling yourself is real. I'm real. Kind of a feeling. Okay. So fifth rumination, C true, E true, D false. Okay. So, okay. If there are any questions, you can ask from me. So because it's a lot of taking time, so I will be going little fast, but clarify after clarifying your doubts. Okay. Okay. So shall we move on to the next question? Question 5. Yeah, I can tell you. So A true, B true, C true, D false, E true. Okay. So shall we move on to the next question? Now, okay, there's another message I have got. Okay. So that's only me is talking now. So can somebody, if you want, you can speak up and tell me the answer for the A. I don't know whether you are sleeping or not because it's 9:50. So sixth question, experiences which need a psychiatry referral. A, when I go out, all the time I'm being followed by the Indian intelligence force. So what sort of a, okay, somebody is telling me that's Kavindu is telling me it's true. Good. Yes. When I go out, all the time I'm being followed by the Indian intelligence force. So how could that be like? How likely it can be real? No, it's very unlikely to be real. I am being followed by, like, what sort of a delusion is this? Yeah, it's delusional. Very good, Marine. I think I hope I have pronounced your name correct. Pardon me if I incorrectly telling Marine, I hope. Yes. Delusional, very good. Yes. So what sort of a delusion is it? It's a delusion. Yes. What sort of a delusion? Kind of a persecutory, no? Yes, very good. Yeah, Kavindu, very good. Yes. So it's a persecutory delusion. So you need a psychiatric referral. That patient needs a psychiatric referral. Okay. So B, I woke up in the middle of the night after seeing a bad dream and could not fall asleep again. Does that need a psychiatric referral? Good. I'm getting yes, false. False. Yeah, that's false. It's a normal experience that you and I can have. Yeah. So, see, you may think I am mad, but I always question on existence of the God. Does that need a psychiatric referral? In your answers, yes. Hmm. Good. No. Yeah, we also at times we also tend to question about the existence of God, no? Yeah. So it's not that doesn't need psychiatric referral. So D, sending a rocket to the sky is not a big thing to me. Do you know why? Because Abdul Kalam gets advices from me before sending every rocket to the sky. Does that need psychiatric referral? If so, yeah, it's quite, I'm so happy because I'm getting a lot of correct answers. Yes. So if so, what sort of a psychopathology is it? Very good. Yes. It's a grandiose delusion, no? Kalam gets advices from me. So it's grandiosity before sending every rocket to the sky. Okay? It's a grandiose delusion. Feeling grandiose. You can have these sort of delusions in mania, no? Bipolar affective disorder, manic patients can have. Okay? So E, I can't live without him. He is still in my memories. Does that need psychiatric? Of course, yes. Yep. Somebody we love, so left. So we might remember him for our life. Okay? Somebody died, husband or the wife died, so the other partner will remember him until death. Okay? So that's a normal phenomenon. So the answers A false, A true, A true, B false, C false, D true, E false, true, true, false, false, true, false. Okay. I think you, yeah, thank you so much, Interact, for uh, the kind, like active interactions. No? So, okay, that's good. So, yeah, this is kind of a different one. So, this is wrong. It's ticks. Which of the following are motor tics? I hope that you have heard about tics. The repetitive motor tics are repetitive kind of movements, physical movements. Okay. So, which of the following are motor tics? Have you seen like repetitive blinking of eyes? Yeah. So some people, like when they're very anxious also, they tend to blink more. And some people commonly, like frequently have this eye blinking. So which is called a simple motor tic. Okay. So repetitive blinking, eye blinking. So then it's true. So there are motor tics as well as vocal tics. Okay. Simple tics, complex tics. Simple means there will be only just one tic. The motor movements, like kind of, and complex will be there, will have lot of complex motor several motor tics. So the motor tics will be there are repetitive eye blinking, shoulder shrugging, eye rolling up. Okay. They can have clenched fists as well. But the B, slow rhythmic movement of the forearm. The important fact is motor tics are non-rhythmic. The tics, these are non-rhythmic. They are not rhythmic. Okay. So usually epilepsy, there will be some sort of a rhythmic kind of movements. So then when you see other types of like movement disorders, there will be rhythmic type movements, but here motor tics are non-rhythmic. So A true, B false, C true, D true, E true. Okay. So then these are about motor tics. Okay, there will be a lot of more, like there are several types of motor tics. Okay. So, and there will be vocal tics. Simple vocal tics like just sounds, repetitive sounds will be there. And sometimes they will utter words, phrases. So kind of a complex vocal tics. So they will tell like suddenly utter bad words, kind of a filthy words, which is called as coprolalia. Okay, so those kind of things can occur in vocal tics. So motor tics, vocal tics. So these tics can occur in several like kind of conditions like neurological. Usually it's a neurological condition. So Tourette syndrome is one of the condition where you can see these tics, complex motor vocal tics both. Okay. Yeah, here that's a good question. So they are asking about motor tics. They have not specified about simple motor tics or the complex motor tics. So here, generally they have asked the question. So you can consider both simple and complex. Yeah, because it's not specified. Yes. Okay. So I hope you have got it correct. So let's move on to the 10th question. So regarding obsessions, I think this is easy for you guys. So regarding obsessions, thoughts are identified by patients as senseless. I have already told you. It's true. Patient feels thoughts are inserted by outside agent. What is it? Is it an obsession or something else? Or if it is something else, what is it? Yeah, that's false. Yeah. Then what is it? The P. I'm talking about P. Yes, in schizophrenia. You can get it in schizophrenia. So what is the psychopathology? Yeah, very good. Thought insertion. Yeah. The patient feels thoughts are inserted by outside agent. You call it thought insertion. So thoughts are taking out by some withdrawing from themselves, their mind. So it is called thought withdrawal. Thought insertion and thought withdrawal. You can see in specifically like it can be seen in schizophrenia, which is a first rank symptoms in schizophrenia. Okay. We all together call it thought alienation. Okay. The term thought alienation, thought insertion, withdrawal, thought broadcasting. Okay. So thought broadcasting is the thoughts can be known to other people without telling. Okay. So these can be seen in schizophrenia usually. So that's false then. It's not an obsession. Okay. Thoughts are identified with the A true, B false. Patient tries to resist it. I told you they are in severe discomfort. So they know these are senseless. purposeless. Okay. So they try to resist it. So they fails. Okay. So patient tries to resist it. That's true. D. Patient usually try to relieve with rituals. That's also true. What is the name called? Like what we called it? The rituals. The term that we call. What is the term? We call them as compulsions. Yes. Try to relieve them with rituals. E. Usually unpleasant thoughts. I told you they are very unpleasant. So, true. Ego dystoning. No, last time I have told you these obsessions are ego dystoning. They are not tallying with your morals. Okay. Your values. So, they are ego dystoning. So, then A true, B false, C true, D true, E true. Okay. Yes. So let's move on to the next question. So this is regarding obsession. Yes. Hallucinations. Again, it's about hallucination. Okay. So I hope that by now you have understood the stem may occurs within patient's environment. True or false? I have clearly told you it's occurring in outside of the patient's, like patient's environment, like outer objective space. So that's false. They occur due to problems in sensory organs. I have already told you hallucinations can occur in where? Problems in sensory organs, I told you. In visual impairment, in hearing impairment, no? They can have this hallucinations, visual auditory hallucinations. So they occur due to problems in sensory, yeah, they can occur due to problems in sensory organs. But not always, okay? They can. See, visual hallucinations are organic in origin. Usually, visual hallucinations occur in organic conditions, okay? Like in visual cortex, like space occupying lesions, tumors, in eye problems, as I told you after cataract surgery, in visual impairment. So they can have are organic in origin. This stem, there's a problem because visual hallucinations usually be in organic origin or can occur due to organic conditions. That's true. Visual hallucinations are organic in origin. What I get is, like always, they are organic in origin. Because it's not always organic in origin, when you mark this stem, there will be a problem. Okay. I hope that you get my point. So these MCQs are very tricky, though they look very simple. Visual hallucinations are organic in origin. Are not organic in origin? Keyword it's false. Can occur in organic conditions, but visual hallucinations are organic organic in origin. So you get the problem. They are not always organic. They can occur in other psychiatric conditions as well. Okay, you can see them in normal people. Normal people also can get in grief. You can see, okay, visual hallucinations. So other psychiatric conditions you can have, not very common, but depression. So other conditions also you can have. You can't say you don't have. So as an example, in depression, you see coffins, you see fire, you see like kind of monsters dragging you, kind of hallucinations, visual hallucinations you can have if the depression is so severe. So the C stem is quite tricky, like little tricky. Okay. If I am you, that's one sort of a stem that I will avoid marking. If there is the word always organic or in origin, I will mark it as false. Uh, not organic origin, also I will mark it as false. Can occur in organic conditions, I will mark as true. But this time, visual hallucinations are organic in origin. I'm not very sure whether they mean this is always or not. So that's the sort of question that I will, if I were you, I will avoid. So, but get the message, the idea behind the question. So they can ask in different ways. They can be asked. So D, deafness rules out possibility of auditory hallucinations. I told you in hearing impairment, they can have auditory hallucinations. Deaf people also can have auditory hallucinations. So this is false. Deafness cannot rule out possibility of auditory hallucinations. Okay. So poor eyesight is a risk factor for visual hallucination. True, I told you. Okay. So I'm not going to go and describe in detail about it because I have already told you. I will repeat the same. Yes, Charles Bonnet, yeah. Yeah, poor eyesight. In Charles Bonnet, you can have visual hallucinations. Yes. So, yeah. So these are true false MCQs which are very familiar to you. The interesting parts are coming. These single best answers that I mostly want to do these because you have not have got any exposure for that. So yeah, we have discussed this. Yeah, this is interesting. So try whether you can identify this. A university student presented to the clinic saying that his thoughts are known to his friends without talking about it with them. Okay. Important keywords. His thoughts are known to his friends without talking about it with them. He also says his neighbor is trying to insert thoughts through the CCTV camera to control his actions. He also hears his friends talking about him and planning to kill him. What are the psychopathologies present in this patient? Okay. Yeah, I'm getting answers. Yes, we'll see. Hmm. What are the psychopathologies present in this patient? I have got the answer C, T. This is not single best answer. This is true and false. There could be several answers. Yes. A, C, T. Yes. Okay. So I have got some answers. So we'll go one by one. A university student presented to the clinic saying that his thoughts are known to his friends without talking about it. So what is that? It's, I have mentioned you little earlier, thoughts are known to his friends without talking. He has not talked about these thoughts to friends, but his thoughts are known to them. So that's called thought broadcasting. Okay. So A, true. He also says his neighbors is trying to insert thoughts through CCTV camera to control his actions. That's thought insertion. Okay. He also hears his friends talking about him Okay, that's important. About him and planning to kill him. Okay. What are the psychopathologies? So obviously there is thought broadcasting and thought insertion is there. Okay. Here's his friends talking about him. It's third person auditory hallucination, not the second person. Second person auditory hallucination is like if the friend is talking to the patient, talking to him and telling, I will kill you, I'm going to kill you. Okay. So that's second person, directly talking to the person. But here, talking about him. So they are conspiring. Friends talking about him and planning to kill him. So they hear some voices talking about him, not directly to him, no? So it's third person auditory hallucination. So among themselves, they are talking about him and planning to kill him. So what I see is there, thought broadcasting is there, thought insertion is there, third person auditory hallucination, not second person, and planning to kill him, there are persecutory delusions. The answer list is not giving that answer, but there are persecutory delusion. Delusion of control is not actually there, but he says camera to control his action. It's not mentioning like at the time they are controlling him, they are trying to control. Okay. So usually if that's thoughts and his acts are controlled by the other people, so we call it delusion of control, but this is they are trying to, not controlling. So yes. About thought broadcasting, should be there any broadcasting media? No. No. Okay. Thought broadcasting means like your thoughts are known to the others by any means. Sometimes they tell like they through CCTV, they get to know, through any sort of a computer system, they get to know. Okay. So through some mean, like unrealistic mean, they are trying to, like they get to know their thoughts. Okay. So broadcasting mean like the term though tells it as thought broadcasting, it's not like that. Okay. So there is another entity called like they are talking about him in the TV, newspapers, media. So that's delusion of reference. Okay. The TV person is talking about, okay, camera to control his action. Isn't it delusion? Yes, that's what I'm talking about. I was talking about insert thoughts through CCTV camera. It mentioned as trying to insert thoughts, yes, through CCTV camera to control his actions. It doesn't mean that at the moment they are controlling his actions. So if he believes that his actions are controlled by the neighbor, okay, then it's delusion of control, but it says like they are trying to control. Okay, he's not very much convinced that his actions are controlled yet. So that's why we can't take it as delusion of control according to the given scenario. Okay, that's good you have thought about it. But at the moment, you can't take it as to control. If he says like, at the moment they are controlling my actions by this mean, so this is, it can be delusion of control as well. Okay, I hope that you have got my point. Yeah. So A true, B false, C false, D true, E false. Okay, so we can't get any anxious effect from this scenario, no? Because if it is mentioned like he's very much anxious now, okay, going to the police and take action kind of, then we can think about it, but it's not mentioned in the scenario. Okay, I hope that you have understood about this. That's a good question, I think. So yeah, what are the normal experiences? I have explained to you. No need to repeat. I think hypnagogic, yes, normal people can have forgetfulness. We all have forgetfulness to some extent. Okay. Obsessional ruminations? No. Obsessional ruminations occur in OCD. Okay. So persecuted delusions? No, they are not normal. So occur in psychiatric illnesses. Illusions? They can be normal. Experience like pareidolia. No. So we can see visual illusions, kind of other visual ones. So then, uh, yeah. So true, true, false, false, true. Yes. Visual hallucination again indicates an organic pathology. That's true. If there are visual hallucinations, most of the time, we have to think about an organic pathology. In this wording, indicates an organic pathology, indicates no. Yes, we can take it as true. Lilliputian, I was talking about you like I was telling about this Lilliputian hallucination before. Okay, Lilliputian hallucinations are special kind of hallucinations where people see big objects as smaller ones, like very small ones. Like if you see small elephants, like these people can see small elephants, like swimming in the fish tank, kind of, okay? Very like big objects they see as very smaller ones, okay? So Lilliputian, we called it as Lilliputian hallucination. So are seen by patients with alcohol withdrawal, yes, delirium tremors. It's the patients with delirium tremors in alcohol withdrawal, they can have. Yes, somebody has answered. Yeah, good. Uh, Seen by patient, true. Yes. Is a clinical feature of visual impairment, true. Hallmark feature of schizophrenia, visual. Kavindu, you have got first three. I'm so happy. But the D, hallmark feature of schizophrenia, no. So visual, it's not a hallmark feature. It's not mentioned in the criteria as well. Okay, they can have, but it's not a hallmark. Auditory hallucinations, they can have, like, but it's not. Is present in grief reaction. Grief when you lost somebody, lost something, okay, lost job, lost marriage, lost your partner, okay, you can have grief reaction, dead or lost. So then they can have visual hallucinations, like they see in normal grief also, they can see like the people that they can see the presence of the dead person, okay. So as a grief reaction, they can have. So that's true. I think somebody have asked about Todd syndrome. Are you talking about Todd's paralysis and regarding which, I hope you are talking about this question. Answer B. Okay. Yes. Yeah, they can have Lilliputian hallucination. Yes. Todd syndrome people also can have. Yeah. But they can occur in alcohol withdrawal as well. Okay. Uh, true, 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 false, true. Yeah. So let's move. Regarding insight. Okay. Insight in a mental state examination. So we are talking about insight. Okay. So aware about the like there are 4 points that we are talking about in the insight in patients. So one is whether they feel like there's some change, okay, psychological kind of a change in themselves. Okay. So the other part is like whether they feel like the other people also have noted some change in him. Okay. So, and he believes that he or she believes that he is having a psychiatric condition, and he is willing to the fourth one, whether he is willing to take treatment. Okay, there will be 4 components in the inside. So aware about the morbid change in oneself. Yeah, insight, if the patient's insight is good, they will be aware about the morbid change in themselves. Okay. So insight in mental state examination is stated as present or absent. Usually we say the patient is having good insight or poor insight. Okay. You can tell the insight is present or absent also. Usually what we are stating is insight is good or good. The patient is having good insight or poor insight. Not the usual term is not the present or absent actually. So that is little tricky. So in that I don't know what they have meant by this. So usually insight we tell whether it's good or poor. I will double check. So in textbooks also says it's not merely present, mentioning present or absent. So we usually tell it as good or poor depending on the several factors that I have mentioned you about 4 factors. So I think this is false. Poor or good. So good insight has good compliance. Yes, true. Good insight has good compliance. If you have a good insight, if the person is having a good insight about the condition that he is having, the compliance will be good. Otherwise, the compliance will be poor uh, because they will not agree to take treatment. They will not believe that they are having a psychiatric condition. Okay. So just remember the 4 things that we have to look when we are seeing a patient to assess the insight of the patient. So whether they feel like there's a morbid change in themselves, whether they think that the other people also have noticed change in him, and whether he thinks there is a psychiatric problem in him, and whether the patient is willing to take treatment. All 4 things has to be uh, fulfilled to call it as having good insight. So in between, we say it's a partial insight. So if first 2 is also fulfilling, the latter 2 is not fulfilling, usually we call it either usually partial, we can say partial. So absent in neurotic diseases, I have told you in my first lecture, like neurotic diseases, usually we called OCD, anxiety disorders, those sort of disorders, not the psychotic ones. So usually these neurotic people, they have insight, good insight into their illness. So psychotic illnesses, the insight will be usually poor in schizophrenia, bipolar, okay? So, sorry, bipolar, with usually bipolar is not psychotic per se, it's a mood disorder. So schizophrenia, schizoaffective, delusional disorder, they will have very poor insight. Bipolar also, uh, though it's a mood disorder, they will have poor insight most of the time. So A true, B false, C true, D false. Hope you have got that correct. If you have any questions, you can ask me. Yeah, let's move to the uh, yeah, the 14 questions. Catatonia is associated with. I hope that you have heard about catatonia, which is a neuropsychiatric sequelae. Have you heard about it or not? So then I can understand what extent that I have to explain to your level. Because these are final MBBS questions, like these ones I have taken from, I think, Peradenium papers. So not your ERPM, but they can be asked. Okay, forgetfulness hit on me. Yes. Okay, so yes, catatonia is kind of a neuropsychiatric condition. So you can see this catatonia, the entity in psychiatric conditions, schizophrenia, bipolar, depression, as well as non-psychiatric kind of organic conditions as well. Okay, there are several organic conditions, systemic, like it could be, there are several. Okay, so then there are list of signs and symptoms. So I don't know whether I can share it with you. I have a list of symptoms. We'll see whether I can share them with you. I hope I will put it into the chat box. Stop. Just, yeah, I have a screenshot. Try whether you can see it's quite big, and I don't know whether it's clear for you. Okay. So there are several features of like in catatonia. Okay, they have mentioned, I don't like, you don't have to be thorough with it, but thorough with this, but just have a look and be familiar with these terms. They can have stupor, excitement. There are some terms, waxy flexibility, ambitendency, okay, catalepsy. There are lot, rigidity, grimacing, posturing, okay. You don't have to buy hard all these, but little bit familiar with these terms because they can be asked in your MCQs. So I have another screenshot. I have another one. Yeah. So these, you can see what are the medical and neurological causes of catatonia. Okay. In CNS infections, encephalitis, structural CNS disease, seizure disorder. Okay. There are a lot. Stroke, delirium, Parkinsonism. Okay. You don't have to buy heart, but there are several. So the diagnostic criteria will include the third one, like stupor, catalepsy, waxy flexibility, mutism, negativism, posturing, mannerism, okay, primacy, equalaria. So the question actually, catatonia is associated with. When you go through the list, you will find out this waxy flexibility, ambitendency. Okay, the explanations also given in the right side. Okay, waxy flexibility means like when you keep the hands of the patient, like he will be like that. So he will maintain that posture. Okay, if you keep them up. Okay. So likewise, there are several. You don't have to buy her. Just little be familiar with this terms. You want to know the source, I think. Yeah, this is from MedEdge. There's a article. If you want, I can share it with you. Uh, it's a journal article. Okay. Yeah. So you can go and type catatonia MedEdge. Okay. So I'll write it MedEdge. MedEdge. Yeah. So this is a journal. So from where I have got these. You didn't get it, no? So I think I can't send it. I don't know whether it's too big for you, maybe to send. I will send you the link. So then you go and just check these boxes, okay? Tables. Catatonia MedEdge. So you will find it yeah, it's there. So I will share the link. So then you can go and just don't go and read the whole stuff because it's too much for you guys. Okay. So I will share the link and just see the boxes. Okay. Okay. Sorry. Can't I share to all of you guys? Meeting group chat. Okay. Okay. Go and check this link and you will get it. So just go through the what's that? Tables. Okay, so you will find it out like ambitendency is there, waxy flexibility is there. Okay, apathy will be not there. Apathy means like you don't have any emotions, like in severe depression. So in depression, you are not feeling emotions, you are not motivated, kind of. Okay, so it's not there in catatonia. It's you can see in depression or other psychiatric conditions. So inappropriate smile is also not there in catatonia. So reverse excitement you can see in catatonia, like they have mentioned in excitement, but in reverse excitement it means like opposite of the excitement. So when you're very excited, like when the patient is very agitated, very active, so then go and they will be get very slowed and movements will be very less. So they will go into the reverse excitement. So catatonia, they can have reverse excitement as well. Okay. So answers false, false, true, true, true. Just go through those tables and be little familiar with the terms. If you, by chance, if you get a question, so then you know the terms. You don't have to know about this in detail. Okay. So any questions? So now we are moving to the interesting part. There's only, I think, less than an hour is left. So, okay, shall we move on to the single best answers? So, yeah. So we'll do some, depending on the time that we have. Okay. Okay, so that's an interesting question. A patient gave the follow. These are single best answers. So you will have only one answer. So go through the scenario and try to figure out what it is. A patient gave the following answer when you inquired about his medications. I am an olanzapine doctor. Olanzapine, olanzapine, olanzapine. You know there is a famous singer called Lanez. You know I can sing very well. There was a famous song about mothers, but I feel very sad because my mother died when I'm little. Okay. So they're asking, what is the underlying psychopathology? Okay. So is it loosening of association? Is it derailing? Is it neologism? Is it flight of fight ideas, flight of ideas? Or is it perseveration? So you can write the answers. Hmm. Fabindu is telling it's D. So any other guesses? Okay, somebody is telling A, C, okay, D. Hmm. Okay, okay, I have, yeah, somebody is telling D. Yes, okay. So it seems majority is going for D. We'll see. Somebody is telling B. Yes. So in single best answers, so you have to read the given text very carefully, okay, to figure out what is the best answer. Okay, this question actually there's no doubt, but some questions you will get at the end of reading. After you read the question, you will get several answers. So you have to choose between at least two answers. But here it's straightforward. So here, what you can see, I am on olanzapine, doctor. Olanzapine, olanzapine, olanzapine. So then he just to go and talk about a famous singer called Lanez. So Lanzi Lanez. There's some connection, no? So you know I can sing very well. So then singer, sing. Famous, sing, then song. About mothers. Then from mother, my mother died. Okay. So there is some connection, no? You can see there is some connection, okay, in between the lines. His thought stream, you can find some connection, but he's jumping from one topic to one with these connections in between, no? Zipping, Lannis, then song, singer, song, mother, okay? So the majority of you told it's flight or fight ideas. Yes, it's a flight or fight idea. So because there is some sort of a connection in between lines, it's not the meanings, but the association, no? The similar sort of rhyming, kind of a similar sort of words were there. Okay. So that's flight or fight ideas. The pressure, they have lot of pressure, like the thoughts are coming, the lot of pressure in thoughts. So then they can have this sort of, especially in bipolar manic patients. Okay. Loosening of association, there will be no any connection. You cannot find any association in between. So where you can see in schizophrenia. Okay. So derailing also is a formal thought disorder, part of a formal thought disorder. You will jump one line to one line. There won't be identifiable connection, topic to topic, without any connection in between. A neologism, you will tell completely new words. Okay, there will be a lot of new found words, no meaning. Okay, neologism, that's also you can see in schizophrenia. Then perseveration. Perseveration means you are repeating the same answer. If you ask, um, what is the you ask what is the day today? So they will tell, okay, the first of April. So then you again ask, what is your name? Where are you from? Then again they will tell 1st of April. Okay, so they will repeat the same answer to all the questions that you are asking. Okay, perseveration. So this is flight of ideas. So the best answer is flight of ideas. So flight of ideas, you can see there are people like who are having flight of ideas. There will be whole clan association. So they will go by the sound of the word. So then they will go and jump into the topic to topic with that. Okay. So then again, the rhythm of the words will be similar. Okay. And there's called punes fonts. I don't know how to spell it. So there are words that have two meaning, like suppose a word which has two double meaning. So then they will tell it and they will jump into the other meaning of that word. Like they will start a topic with the other meaning of that word. Okay, so there are different types of actually three types of flight of ideas. So this is one. Okay, they will go with that sound of this sing song. Okay, so there is a connection. So this is obviously flight of fight ideas. So okay, there's a question somebody have asked. Echolalia, no. Echolalia is repeating the same thing that you are talking about. You are telling. So if you ask what is the day today, he will also tell what is the day today, not the answer. Okay, if you ask what is your name, he will tell what is your name. Back to you. Okay, what you are telling, Arapunchikale, like when we were young, we used to do some like silly things, no, like we were talking, if somebody talking, we used to repeat the same thing to annoy that person. So, echolalia is that, not to annoy, but the condition gives rise to echolalia, underlying psychiatric condition. Like we see echolalia in autism. Okay. So that's echolalia. I hope that you have got the answer. So shall we move on to the next question? Yes. Try. This question, a 30-year-old man is seen in the outpatient department. He complains that a group of men are following him with the intention to harm him. He also complains that the newsreader on the television is talking about him. He believes that the newsreader is sending special messages warning him that he is in danger. Which psychopathology best explains the belief of this patient that the newsreader is sending him special messages? Okay, read the question carefully. Okay, which psychopathology best explains the belief of this patient that the newsreader is sending him special messages? Okay. Okay. Marin is telling it's C. Ganidu is telling it's D. Illusion of reference. Somebody is telling it's a persecuted illusion. Okay. So, what they are asking, which psychopathology best explains the belief of this patient that the newsreader is sending him special messages? So, he believes the newsreader is sending special messages warning him that he is in danger. So, that newsreader is helping him because he is warning him that he is in danger. He is supporting him, no? Because he is warning him. Okay? So, then it's not a persecuted illusion then. So he complains group of men are following him with the intention of to harm him is a persecuted delusion. Yeah, that's true. Okay. He also complains that the newsreader on the television is talking about him. That's delusion of reference. Okay, he believes that the newsreader is sending special messages, warning him that he is in danger. So that's a part of the delusion of reference. Question they are asking the question, which psychopathology best explain the belief of this patient newsreader is sending him special messages, not the men are following him with the intention to harm him. That's delusion, persecuted delusion. Okay. I hope that you have got my point. So this is delusion of reference. So somebody is referring to him, the newsreader is referring to him, okay, and telling him that he is in the danger and warning him. Okay. So he is talking about him. So that's a delusion of reference. Hope you have got the point. Okay. So that's why I'm asking you to read the question properly and see what is they asking. So there might be relevant other parts included in the question, but they're asking something else. Okay. So hope you have got it clear. This is delusion of reference. Okay. Yeah. So shall we move on to the third one? What is this? Patient from UK presents and on initial consultation utters the following statement. Hello, they are dog. I put the kettle, you know, potty like a lottie, became putty and but they are nutty. What is this? Potty, lottie, putty, nutty. Okay. What psychopathology is best described as? Is it loosening of association? Is it egocentric speech? Is it word salad? Is it flight of ideas? Is it perseveration? Hmm. Nobody is thinking is D. Can it be flight of ideas? Flight of ideas. Nobody, no? Yeah, you see there's a rhyming. Potty, lotty, putty, nutty. Yeah, there's a nice rhyming in each word, like sentence he is talking, no? Okay. So that's also you see in flight of ideas. So I told you like they can have like either like the forget about the meaning, but you can find there's some connection between the rhyming of the words, no? Okay. Potty, lotty, putty, nutty, no? So that connection is there. Not the meaning per se, but the words are interconnected. Okay. So similar sounds, no, rather than the meaning. So you call them as clan associations. Okay. So these words linked based on their similar sounds. Okay. Rhyming. There's a rhyming. No? So you can see them in bipolar, sometimes in schizophrenia as well. So these are called clan associations. So it's a type of flight of ideas. Okay. So I hope that you have got it clear. Okay. It's a little difficult, but you see there's a nice rhyming of the words. So that rhyming, the sound is interconnected, not the meaning. Okay. Hope you have got it. loosening of association, no connection at all. Egocentric speech means like small children when they are playing, they talk to themselves like I'm doing this, now I'm doing this, like talking to self. Word salad, you cannot get any sort of a connection and no meaning at all, like jumbled perseveration I have explained to you. So I hope that you have got it. So little difficult. This is little difficult, but you have to know there are several types of flight of ideas. One is they can interconnect with the meaning of the similar meaning of the words, or the rhyming or the sound, the similar sounds. So they can be interconnected. Okay. The connection is not merely the meaning, not the meaning of words. Okay. The rhyming also can be there. The sounds can be similar too. Okay, so that's what I have actually selected this question to tell you. Okay, this is a different kind of flight of ideas. Okay, shall we move on to the next one? Hope I have not confused you. Okay. So tell me if I have confused you, guys. Okay. So, okay, I hope you can get this clear, this one correct. A 50-year-old man refuses to go out from home because a group of people are talking and gesturing about him on the road. What they talk is not clear, but he thinks they are talking about him. Okay. What is the psychopathology? Okay, I'm getting several answers. B, okay, E, B. Yeah, because it's time limited, so I will tell you. So, refuses to go out from home because a group of people are talking and gesturing about him. What is that? It's reference, no? It could be ideas of reference or the delusion of reference. Somebody is talking like about him or gesturing about him. Okay? He believes on the road. What they talk is not clear. He can't clear it properly, but he thinks they are talking about him. He cannot hear it properly. So hallucination, you can hear it properly. Okay, commentary hallucinations, he will hear it properly. Okay, that they are talking, commenting about his each and every action. Okay, like a commentary. Okay, so but he thinks. So that's a thought. So it's a abnormality of thought. They are talking about him. So it's a kind of a reference, thought about reference, like the idea of reference, but it's not very convinced whether it's a delusion. They have not mentioned whether he firmly believes, but I think it's up to delusional. It's there up to delusional level because he's not not going out. Okay, functional deterioration also there. So, but the given answer is ideas of reference. So it's not obviously social anxiety. Persecutory delusion, no. They have not mentioned anything. They are trying to harm him or something. So not second person auditory hallucination. They are not talking to him. Okay. They are talking about him, no. So it should be third person. Commentary hallucination, no. So the only answer is the ideas of reference. I think it would be better if there's a delusion of reference because it's probably up to the delusional level. No, he's firmly kind of believing it seems. Okay, but the answer is ideas of reference. Hope you have got it. So we have left with another 3 questions. It's 11. Do you want me to continue the other 3 questions also? Or is it enough for today? You can guide me. Okay. We'll see. Yes, continue. Okay, thank you. Okay, so next question. 40-year-old female was brought to the hospital because she has been throwing stones at her neighbor. She worries that they are trying to kill her and believes that they send bad thoughts into her head through computer rays. Which of the following will best describe her psychopathology? So, that's a single best answer question, but little bit tricky one. So you will lost in between probably two answers. Good. How we do is telling me it's B. Okay. Most of your answer is B. Yes. Yep. Yeah. So which of the following will be best? Yeah. So she worries that they are trying to kill her, whether this is a delusion of perception, and believes that they send bad thoughts into her head through computer rays. So thought insertion, they have not mentioned about thought broadcasting, thought withdrawal, or thought echo here. So you will be lost in between delusion of persecution or thought insertion. So how you are going to differentiate whether it's A or B? So the wording, she worries that they are trying to kill her. It's not that she firmly believes, or she believes that they are trying to kill her. She worries that they are trying to kill her. The other wording believes that they send bad thoughts into her head through computer rays. So the wording of these two sentences, the much gravity is there in this, believes that they send bad thoughts into her head through computer rays, no? So then it's obviously thought insertion. Worries means like 50-50 kind of. It could be idea of persecution or the delusion of persecution. She's not very much convinced according to the how they have worded. Ne? So then the B is the correct answer. Good. You have thought about it. Yeah. That's a difficult one. Yes. Okay. The next question. Again, sort of a similar one. 40-year-old patient talks loud and fast. I go to the garden, see a red flower, Communist Party, party politics, President of Sri Lanka. So is it pressure of speech, pressure of thoughts, perseveration, stereotypes, light of ideas? Okay. Do you see connection in between? I go to the garden. So in the garden, see a red flower. Communist Party. Red, like the Communist Party, usually their colors are red, no? And the party politics. And the politics then jump to President of Sri Lanka. So there is some connection in between his thoughts. Okay. Okay, so now I hope that you have understood. Yes. Is it perseveration of ideas? No. It's also a kind of flight of ideas. Okay, I have included all these flight of ideas, no? So, yeah, there's a connection in between. The meaning is not, yeah, you have meant E. Yes, not very clear, but he's jumping into one from one, but there are some connection in between his thought. Garden, flower, the red flower, Communist Party, the color usually red, and the party politics, the political president, no? So there's some connection. in between, depending on the words that he is talking. So it's flight of ideas. Okay. So, okay, the last question. Nirmala is reporting hearing of voices of unknown people when she is alone. She tells that there are 3 people who talk to her and tell her not to eat because food is poison. What is her psychopathology? 3 people talk to her, tell her not to eat because food is poison. Yes, I'm so happy now you are getting it correct. Yes, it's D. It's second person auditory hallucination. No, I think now you are clear. There are 3 people talks to her and tell her. So directly talking to her, it's second person auditory hallucination. Okay. It's not persecutory delusion because the voices are telling her not to eat because the food is poison, but it doesn't mean that Nirmala is believing that her food is poison. So if there's a statement telling Nirmala is believing that food is poison and she is not eating, that could be persecuted. That is a persecuted delusion. Okay. But here it's the voice that talking. Okay. Good. Finally, that you have got it correct. The last one, you have given good correct answers, yeah, in between. So last one, I'm so happy because Y is not C. She is warned. Yeah. So she is warned, like unlike in the previous one, no? If the news reader is referring to him and telling him, like it's how he perceived, like the newspaper is talking. Yes, he's talking and telling something, but he believes that he is talking about him. Okay? And warning him. Okay? The first thing that he believes that the news reader is talking about him, referring to him. So it's a delusion of reference. Okay. Here, voice is talking to her directly, tells not to eat. So it's a hallucination, no? They are telling about hearing of voices of unknown. Like they are starting with that statement. There are 3 people, talk to her. There's no one in the vicinity. Okay. And she's sure, like she's hearing voice and she's sure that the voices is talking about her, not to eat. That's a hallucination. Do you understand? That's 2 different scenarios. Here it's about hallucination. That's a delusion. Yes. Previous one is a delusion. A. Auditory hallucination and secondary delusion. But the facts are lacking, no? To call it is a delusion, we have to know what Nirmala thinks about it. So this is Nirmala hears the voice, not to eat, but it doesn't mean that Nirmala believes that actually her foods are poison. It's not mentioned in the question. Okay, if she believes that is also happening, that her foods are poison, she also believes. So then it could be a delusion as well. But here the information are not adequate to come to a conclusion that the Nirmala is having a persecuted delusion as well. Okay. So that's why it's only second person auditory hallucination, stem D. Okay. If there are more information about her thoughts, then we have to think about the second delusion part as well. Okay. Hope I have cleared your doubt. Okay. So any questions that you want to ask? Are there newcomers like who are not there for my first class and today only joined today? So just to know whether you have got the idea about your exam, upcoming exam. Are there newcomers who joined today only today? Or were you there at my first lecture? Can you just type in the chat? Okay, you have Marin, yeah, one has attended for the first lecture. So that means like others are new. No, I saw some familiar names. Like, I think I have seen them last time. Okay, yeah. Okay. So anyway, so I will be briefly tell you about your exam. Hope that you are sitting for the exam on May this year. Am I correct? All of you are sitting for this year May exam. Okay. 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 So last time also I have told you that there will be 15 true false MCQs and 17 single best answer questions in your paper 3. Okay, so which will account for about 1/3 of your marks of the third paper. So that's valuable mark, like kind of 1/3 means like quite a lot. So then, and there will be OSCEs as well. So one station from Psychiatry out of 18 test stations. Like there will be 20 test, 18 test and 2 resting stations. So one will be from Psychiatry. So I feel like I think that if you do well in your psychiatry, so you can get quite a lot of marks from your third paper because you have to pass the third paper, like all 3 papers to get through your ERPM. So I don't think that they will ask very difficult questions. Okay. Usually they will ask these sort of type of questions from you guys. So this is only about psychopathology. There will be other topics that we have to discuss before the exam. Because you have been asking about this, you have asked about this paper classes, no? Like you need to, like the paper, need to be engage in more of these discussions, paper discussions. So I also think that you will be benefited from these paper discussions. So study, like do the past papers, like get down your past papers, print them or having them in your computer, and then try it, time it and try to do it. Okay. So uh, uh, then if you have any clarification, like need to any clarification, so you can ask while during the classes, as well as I think they will give you, management team will give you opportunity to ask questions later. So that's good that you have interest in participating in these lectures and interacting with me. So you can learn a lot if you interact. Otherwise, I don't know what to what extent that you know and what are the areas that you are lacking uh, uh, in knowledge and what areas that you need. Okay, then I can, if I know your feedbacks, like I got your feedback last time also. So then we can tailor-made these lectures to your need. Ultimately, that's what needed, no? Rather than telling the stuff that I want to tell you. So if I can teach you what do you really want, So I think you will be benefited more. So hope that you are studying, uh, and hope that you all can get through the RPM exam and welcome again. Then you can join us in a community. So yes, we need a lot of doctors uh, to work with us because we are in shortage in all the resources, including human resources. So I hope that you have that you can get through the RPM successfully and join the career. So for that, we'll do this as a collective work. Like we all, you can also interact, and we are also helping maximally to go through your get done do well in your ERPM exam. So okay, thank you for your feedbacks. Okay.